So when we come towards mental health, mental status examination, so as an introduction, I would like to tell mental status examination is a window into patient's mind, psychiatric equivalent of physical examination. And we nurses, why we have to use mental status examination is to observe systematically and to communicate the findings with mental health team, other team members, psychologist, psychiatrist, social worker. Okay, and we have to ensure safe and effective mental health care for the patient. What is mental status examination? So when we come to the definition, mental status examination is the structured assessment of a patient's mental functioning through observation and questioning, covering appearance, behavior, speech, thought, mood, perception and cognition. This definition is very important because mental status examination includes appearance and behavior, speech, thought, mood, perception and cognition. Okay, hope you have understood. Discuss in detail about each component. The first category is general appearance and behavior. So in appearance, we look for hygiene, grooming, posture, dress. For example, neatly dressed with the shaved in schizophrenia cases, and we can see the patient's appearance will be little bit changed. And in behavior, we look for eye contact, attitude, motor activity. For example, restlessness, pacing in anxiety, and withdrawn in depression. For depression and in anxiety cases, we can see there will be a behavior changes for the patient. And the next is attitude towards examiner. So sometimes the patient will be cooperative, sometimes will be hostile, and sometimes will be suspicious. So usually in paranoid psychosis, the patient looks suspicious. Okay, so these are the things we see in general appearance and behavior: appearance of the patient, behavior of the patient, and attitude towards examiner. So the next is speech. In speech, we check for the rate, volume and content relevance. In rate, we will see whether the speech is slow, whether it is fast, whether it is forced or pressured. For example, there will be a pressured speech in mania. Patient will be forcing, stressing when he speaks, especially in manic cases. And volume, in volume we look for the loudness, whether the volume is loud, soft or whispery. Fluency and rhythm, also we'll see stammering, slurred or hesitant. And the content relevance, we'll see whether it is coherent or irrelevant. For example, when we ask some questions, usually schizophrenic patients will be telling the irrelevant answers. Okay, so in speech we check for the rate, volume and content relevance of the content relevance what the patient speaks. Next we'll see about thought. So in thought we'll see the form of thought and the content of the thought. So in the form of thought we'll see whether it is logical, whether flight of ideas are present, whether the thought is tangential, incoherent. For example, sometimes the patient may tell, I was going to the market, sky is blue, God is calling me. So there will be a loose association between each sentence, each word the patient is telling. So there will be a disturbance in the form of the thought. We have to notice it. And next is when we discuss about the content of thought, we may feel the patient will be having delusions, obsessions, suicidal ideas. Sometimes the patient may tell some of the sentence like my neighbors are controlling my mind with satellite. So there will be a delusion of control present in the patient. So we have to see the content of the thought for the proper documenting of the patient's current condition. Next is mood and affect. In mood and affect, we'll see the subjective feelings expressed by the patient. So it will be in mood, we'll see the patient's own feeling. For example, patient says, I feel sad all the time. And affect, what we see is what is the patient feels objective, what we feel after seeing what is our observed feeling. So observed emotional expression of the patient to be noticed. So flat affect in schizophrenia, and sometimes the patient will be smiling in mania. And what is incongruent affect, that is mood and affect will not be matching. Okay, for example, the patient will be laughing while describing the death of loved one. There won't be a match between the mood and affect. So we call it as incongruent affect. So like there is mood and affect, that also we have to assess based on the subjective and objective data we get from the patient. Next is perception. In perception, we see the hallucination, illusion mainly, and even we see the depersonalization. So, hallucination, all of you know that false sensory perception without a stimulus. For example, hearing voices, that is auditory hallucination, especially in schizophrenic patients, we can see. And illusion means misinterpretation of real stimulus, like mistaking rope for a snake at a night. Okay, then depersonalization or derealization is feeling detached from self or surrounding. The patient will be completely absent-minded. And next is cognitive function. In cognitive function, we will be seeing the orientation, attention and concentration, memory, abstract thinking, judgment and insight. This is very important. So we'll see orientation of the patient to time, place and person by asking few questions regarding time, place or a person. For example, confused about the date. Usually in delirious patients, we can see the patient will be completely confused about the date, the place where they are. Attention and concentration, we can ask the patient to count a number with a gap, like serial sevens, and spell word backwards. For example, easily distracted in patient will be, if especially in attention deficit hyperactive disorder and all, usually we can see attention distraction will be present. And in memory also we have to check, that is whether the patient is having immediate, recent and remote memory to be checked. For checking the immediate memory, we can ask the patient to repeat digits, and to check the recent memory, we can ask what breakfast you had. Like in remote memory, we can ask any childhood events, any marriage date, all those things. Okay, then in abstract thinking, we can ask a proverb, how you will interpret, how you will analyze the proverb. For example, people in glass house, and we can compare with the concrete answer with abstract meaning. And very important is judgment and insight. So for that also we'll ask some questions, how the patient judge things. For example, in judgment, you can ask, what would you do if you find a letter, if you find a cover with money? So the patient will answer. So based on the answer, we can judge the patient. And inside, we know that different scores are there. That's the patient. So what is the understanding of the patient about their illness? So that we see in the insight. Come to the end. What are the uses of mental status examination? It provides baseline data for diagnosis. It helps in differentiating psychiatric disorders. It identifies the risk factors like suicide or aggression. It assists in treatment planning and monitoring progress, and it enhances communication among healthcare professionals. This is also very important. It provides baseline data. It helps in differentiating psychiatric disorders. It will be helping us to identify the risk factors. It helps in assisting treatment planning and monitoring progress, and also it helps to improve the communication among healthcare professionals. So it is, mental status examination is an essential tool in psychiatric nursing. It helps nurses to observe, understand and record mental functioning, and it builds therapeutic relationship and ensures safe holistic care. And mental status examination is not just observation, it's a skill developed with practice. Okay, thank you.